Hi, I'm a freshman in Cal Poly's Biomedical Engineering program specializing in either tissue engineering or nanotechnology. The topic I am presenting is cancer treatment. It is estimated that 39% of Americans will be diagnosed with cancer in their lifetimes. The typical treatment plan is chemotherapy and radiation followed by surgery. There are three main types of chemotherapeutics. Antimetabolites harm metabolic processes, alkylating agents and mitotic inhibitors damage cancer cells' DNA to prevent replication, while anthracyclines and topoisomerase inhibitors attack enzymatic processes. So why is this not ideal? Chemotherapeutics have an efficacy that is lower than ideal due to their high toxicity, preventing oncologists from administering them in high doses. The drugs may also attack healthy cells, causing severe side effects. When surgery is performed, some parts of the tumor may be inaccessible, and a recurrence of the cancer could occur. Future cancer treatment may involve albumin-stabilized gold nanoclusters modified with chemotherapeutics. The first drug is SN38, a hydrophobic analog of camptothecin, which acts as a topoisomerase I inhibitor. The circled section is SN38's linker, which is sensitive to glutathione. The linker holds the drug to the nanocluster until exposed to glutathione, which is found in high concentrations in cancer cells. The second drug is doxorubicin, a hydrophilic compound that causes apoptosis by binding topoisomerase II or intercalating in the DNA. Doxorubicin's linker, also seen in the circled section, is sensitive to acidic pHs. In theory, both drugs will only release from the nanoclusters when in contact with cancerous cells. The nanoclusters themselves are formed by incubating bovine serum albumin with a gold salt and sodium hydroxide, then introducing thiols using iminothioline, which is necessary to allow the drugs to bind to the clusters. Two experiments have suggested a promising future for this treatment. When MCF7 breast cancer cells were exposed to mono and bifunctionalized nanoclusters at a constant concentration of 2.6 micromolarity for 72 hours, the survival rate of the cells was determined. 100% of the control group and the group exposed to non-functionalized nanoclusters survived, illustrating the biocompatibility of the nanoclusters. 30% of the group exposed to nanoclusters modified with doxorubicin survived, 58% of the group exposed to nanoclusters modified with SN38 survived, and 20% of the group exposed to the bifunctionalized nanoclusters survived, suggesting a promising synergistic relationship between the drugs. The second experiment focused on tumor size before and after exposure to nanoclusters for 7 days. The tumor started out as 465 micrometers across. The average size of the control mammospheres and the mammospheres exposed to non-functionalized nanoclusters both remained 465 micrometers. Mammospheres exposed to bifunctionalized nanoclusters at a serum concentration of 0.08 micromolarity were on average 176 micrometers after 7 days, and when the concentration was increased to 0.6 micromolarity, the mammospheres were 167 micrometers after 7 days. Although clinical trials are still in the future, bifunctionalized albumin-stabilized gold nanoclusters provide hope for more comfortable, more effective cancer treatments.